Hello, everyone, and welcome back to Session 3 of the Completed Life Conference. I am Sarah Kiskaden-Bechtel, your host today and Program Director of the Completed Life Initiative. Today's session is about the philosophical objections and ethical concerns regarding what is a completed life. And today we are honored to welcome a discussion between Daniel Sulmasy and Gloria Ramsey, moderated by Samuel Gorovitz. I'd love to introduce our moderator, who has probed issues of ethics, inclusion, and social justice in medicine and in higher education throughout his career. He is a professor of philosophy at Syracuse University and has been published extensively in bioethics and on other topics in philosophy and public policy. His advice on college governance and on health policy has been widely sought. He has given hundreds of invited lectures on 5 continents and directed many seminars and institutes for faculty in various disciplines, including a National Endowment for the Humanities seminar for college teachers, and a National Institute of Health workshop on research with human subjects. He has been a consultant to PBS, the World Health Organization, and many federal agencies. He emphasizes that philosophy is an ideal pursuit for anyone who thrives on minding other people's business. So without further ado, I'd love to turn it over to Professor Gorovitz, who will introduce our speakers, Professor Sulmasy and Professor Ramsey. Sam?
Thank you, Sarah. It's an honor and a pleasure to have this opportunity. The issues before us are old issues and difficult issues. They involve, at the very least, trying to think as clearly as we can, understanding the difference between good arguments and bad arguments, separating logic from emotion, asking what's the appropriate role of emotion and the way these decisions get made. And so often we have to understand that people are invoking what's called the slippery slope argument, and some of those are good and some of them are not good. So that's the kind of stuff that philosophers are particularly trained to sort out. And that's the kind of work that we'll be doing with a superb panel. Now, I have had the great privilege of working with Dan Sulmasy for many years in many contexts. He's someone of immense accomplishment and distinction. We have served together on a number of New York State Health Department entities, and whereas we have not always agreed, we have always, I think, had the highest possible commitment to the integrity of the argument. And so I will simply say about Dan, check him out, look at his website. This is somebody who is operating in the very highest realms of the highest quality of thinking about these issues. He's a distinguished professor at Georgetown University. When he left New York State, I felt a tremendous sense of loss because I so looked forward to spending time with him, whether we were agreeing or not. We will also hear from Gloria Ramsey, whom I have never met. I've only connected with her anew through this project. And what I have learned is that Gloria is a major international force, trained as a nurse, but also as a lawyer. She has had a global impact on focusing attention on the role of nursing, on respect for nursing, on disability rights, and on unmet needs, and has done so at the highest levels of impact and quality. So it is just an immense honor for me to be able to work with each of these two highly distinguished scholars. And we'll begin by hearing an opening statement from Gloria Ramsey, after which we'll go immediately to a statement by Dan Sulmasy, and then we'll turn to the discussion that will be the liveliest part of our activity. So with that said, let's go immediately to the initial remarks by Professor and Dr. Gloria Ramsey.
Great. Thank you so very much. Good morning, good afternoon. Thank you, Sam, for that kind and generous introduction. And thank you, Sarah, for your administrative expertise during these weeks. Thank you to the Completed Life Initiative for the opportunity to share my thoughts and perspectives for today's discussion. And I would also like to thank you, the audience, for your openness to engage in this important conversation. As I began to prepare my remarks, I'm reminded of the words of Nancy Dubler, and many of you will know her and recognize her name. She's a distinguished bioethicist with whom I studied. And as she so frequently stated, bioethics is about stories. So please allow me to briefly tell you my story and what I stand for and what shows up with me when you invited me to the Completed Life community. What I stand for is respect and equity in myself and others. Over my career, I've been committed to improving the health of diverse populations in both urban and rural areas across the country. I believe that education, and in particular, nursing education, has an essential role in supporting a diverse nursing and interdisciplinary workforce to meet the health and healthcare needs of all persons in our nation. I grew up in a working class, yet resource-strained African American community, racially segregated in the deep rural South. I know firsthand the many faces of inequality, inequity, and oppression, and it is these lived experiences that have compelled me personally and professionally to work to disrupt systems, to identify those structural barriers, and to support individuals to gain access, whether by knowledge or healthcare, and to make informed decisions. Given that social and healthcare justice are my motivation for becoming a nurse, it feels natural to dedicate my efforts to addressing diversity, equity, and inclusion in all that I do, including joining a productive conversation today about respect for autonomy and the meaning of choice, while valuing a life is complete as is determined by the individual based on his or her or their own values as they deem it important. This is why I have agreed to come today and have accepted your kind invitation to build on the contributions made by scholars during sessions 1 and 2 as we advocate for self-determination and dignity at the end of life for all persons, irrespective of their unique characteristics. So what does autonomy look like for individuals, populations, communities who are identified as other. Marginalized groups and communities of color, as well as persons with disabilities, interface with our healthcare system differently when discussing advanced care planning and end-of-life issues as well. As I listened to Dr. Timothy Quill during session 1, who provided a context which included a discussion about hospice and palliative care, he also asked whether it was okay for the dying to hasten death. He talked about Dr. Kevorkian during the 80s and 90s, which I do recall, and the utilization of the suicide machine. He talked about Dr. Derek Humphrey and the Hemlock Society, its role in providing information, as well as medical and non-medical means to persons facing serious illnesses. He talked about Diane, his own patient, and with every historical reference made, I kept asking myself the question, who were these individuals? Did these individuals include members from communities of color, or more broadly, communities that were considered to be other? Last week, in hearing from the clinicians, Dr. Judy Schwartz commented that throughout her long career, she has yet to have a person of color to support. Why is this, you might ask? This is a complex question, multifaceted, but I would offer the experiences of the late Dr. Richard Payne for consideration. Dr. Payne, an African-American physician, palliative care specialist, healer, humanitarian, and bioethicist, when caring for an older African-American male patient with metastatic cancer, severe pain, being treated for prostate cancer with metastasis, given his age and chronicity of disease, he, Dr. Payne, raised the question of home-based hospice with the soon-to-be discharged patient. The patient asked the following question, which really set the trajectory of Dr. Payne's career and professional contributions. The patient asked, "Do you discuss this hospice stuff with all of your patients? Or are you only talking to me about this?" The patient was in essence voicing concerns that by merely suggesting hospice and palliative care, this was somehow suggesting second-class care and was a suggestion of further marginalization of care, as was interpreted by Dr. Payne. This encounter left an indelible impression and had him questioning how many other patients he has treated that had the similar ideals but did not speak. How might this play out if the patient was Black, African American, and the physician, the provider, was white, or vice versa? Dr. Payne credited this patient with being comfortable enough to even confront him, given the tremendous power imbalance between physician-provider and patient. Understandably, it is even more challenging for older adults. And while I emphasize his discussion with this patient, I certainly draw your attention to many advanced care professionals, including my nurse colleagues, who are uniquely poised and are having similar conversations. Over the years of his scholarship, Dr. Payne's, of which I had the honor of contributing through research and educational and training offerings to physicians, nurses, social workers, and others, he and I continued to probe the question about health disparities, health inequities, and these disparities and inequities across the lifespan. Moreover, a faith leader put it this way to us: a generation ago, we could not set foot in this hospital. How can we believe that the hospital has our best interests in mind? By the way, how many other African American physicians are working here who look like you? Interestingly enough, at that encounter, at that time, Dr. Payne was one of 3 African American physicians, where there were 2,000 physicians on staff. And lastly, another faith leader offered, assuming that I could get treatment, why would I want to participate in this advanced care planning process about death and dying? I want access to more services. I want access to greater treatments. I want all the state-of-the-art stuff. Dr. Payne wrote about his experience, and it appeared in an op-ed in the Washington Post with the headline, "End-of-Life Care, Color Still Divides." As we continue to grapple with questions around health inequities and disparities in general, we must recognize that numerous studies have proven that providing palliative care and advanced care planning reduces the burdens faced by patients and caregivers, improves the quality of care provided by addressing the individual patient's preferences, and in some cases, studies have found that care prolongs ill persons' lives. While studies were underway to better understand utilization of advanced directives and hospice services, some found that African Americans likely lack the knowledge of life-sustaining treatments, have greater distrust of the healthcare system, and that their spiritual beliefs may conflict with the goals of palliative and hospice care. So little wonder then that we may not see this population in a more generalized way seeking assistance, aid in dying, or voluntarily stopping eating and drinking. In my own work, I've heard expressions of being mindful. Many African Americans value life, no matter the quality. And despite the information you might provide, there might be a response to a meaningful dialogue that might ultimately lead to a treatment choice preference. Again, we say the point at which any life is complete can be determined only by the individual based on the values they deem important. Yet for some, this fundamental perspective is not firm because for some, the freedom of choice, the freedom of speech, the freedom of belonging, the freedom of fully engaging in society is limited. Structural inequalities, health inequities, Health disparities are present, as is evidenced by reports such as the Institute's on Medicine's report entitled Unequal Treatment, and the subsequent body of literature. Ethical concerns varies when individuals do not have access to care and that their patient, provider, and institutional experiences have led to untoward outcomes. I will conclude by saying the current global health pandemic highlights these concerns, and as COVID represents a unique time in our nation to address these inequities, these disparities, we also recognize that the current pandemic is no exception to what we have known for quite some time. Please know that these remarks are general in nature, and its application is meant to stimulate our discussion in the space of care of marginalized and vulnerable population and those who are disabled. Thank you for the opportunity to share.
Thank you so much, Dr. Ramsey. I consider your remarks to be a tremendous gift, extremely valuable. I have learned much listening to you today, and this is a perfect example of a contribution which will both stimulate conversation and dialogue, but even by itself conveys a tremendous amount of powerful learning. So with great appreciation for that, I'll introduce our second speaker, and we'll go directly to Dan Sulmasy.
Well, thanks to Sarah for her stewardship of this program, and also for her patience with those of us who are less technologically savvy. I hope it's working pretty well for all of you out there in the audience. If so, it's thanks to Sarah. Thanks to Sam for his very, very generous introduction, and also to Gloria for her really very moving and thoughtful remarks that we got to take under advisement very seriously. But I'm hoping that the slides can be shared now with everyone, and that I'm able to do so. I think that's probably the case. Here's what I take to be the point of the project, and I have to say at the outset I'm quite grateful to the project for permitting somebody. I guess I'm really the most contrarian, or the only really contrarian voice you'll hear over the 7 sessions and 14 speakers. But I think we need to begin by saying what's the point of the project. And it seems to me it's this, that the judgment is that persons may autonomously decide that their lives are complete, and also that because they have judged them to be complete, they are no longer worth living, and that they therefore may justifiably choose to make themselves dead with the sanction of the state and the assistance of the medical profession. And I want to be clear at the outset that this aspect is something new. This is not about terminal illness, right? It is about people deciding my life is complete, and therefore I will make my final exit. But, you know, the question arises how one judges that one's life is complete. I don't think that we want to make it something that's completely subjective. Otherwise, no one could be stopped And that's really in some ways a formula for moral chaos. An observation made by somebody like Ludwig Wittgenstein, who said, if suicide is allowed, anything is allowed, right? If you just sort of say, anybody can decide my life is complete, therefore I can end it, then in fact we are saying that we are free to do anything, essentially. And so if we don't want it to be that subjective, we've got to try to figure out what constitutes some kind of criterion that could be sanctioned by the state and the medical profession to allow people to end their lives when they've decided that their lives are complete. So then we should ask, I guess, what a completed life might look like. And I'm going to try to give you a few examples that I can think of that I know from the literature and other places that have been sort of types of examples. And let's look at these. The first might be a case like this one, a 90-year-old man who's well-educated, successful, financially well-off, who has decided that all the projects of his life are now complete. He went to college, founded a business, had a family, retired, enjoyed his retirement, still in good health, but all his friends and family have died. And he just sort of decides, life is over. My life is complete. I should end it now. The state should sanction my asking a physician for assistance with terminating my life. I just want to ask and throw out for our consideration whether that person's life is effectively over. If it really is pretty good, then why quit life at that point? And if your family and your friends have died, might there be other people with whom you might engage in a relationship, particularly if you're well-educated, successful, financially well-off, and able to do that? Other people who would benefit from your wisdom, or if you are that well-off, from your wealth, from philanthropy. Case two, another kind that might come up as an archetype for this kind of project, might be a 90-year-old woman with chronic arthritis and anemia of chronic disease. She perhaps has a devoted husband and children and friends. She's got some fatigue, and she's just sort of bored. And she says that she's tired of life, which I would note is a significant number of the reasons given for requests for euthanasia at the current moment in the Netherlands. Tiredness of life is a category. But again, is this woman's life over and complete? How do we decide if we don't want to decide that it should be totally subjective and up to anybody, even if they're 19 years old? Well, maybe she's not happy now. Well, she's not going to be any happier if she's dead. So what we really ought to ask is maybe what's missing from her life? What could make it better? Could we, for instance, help to make her life better? Could her own attitudes towards life change? What about her relationship with those other persons in her life? And I would simply ask whether we ought to sanction boredom as justification for suicide. Case three, and here's one that I think all kinds of people have in their mind when they're thinking about this, is the fear, justifiable because it's a terrible disease, of Alzheimer's disease, of someone who may be 90 years old with Alzheimer-type dementia who's progressed to the point of being bedbound, incontinent, unable to recognize family and friends, who had previously decided, if it comes to this, my life is complete, it's over, it's not worth living. Perhaps she might have remarked, I would no longer be a person under such circumstances. But if you take that last argument, it seems to me that person and human being are kind of coextensive, aren't they? I don't know if you know any persons who aren't human beings, maybe angels, or if you believe in a deity, certainly, maybe an extraterrestrial. I don't know who that would be. But certainly the archetype we have, the paradigm for a person is a human being. And I'd ask whether we think there are human beings who aren't persons. In some ways, this drives a lot of philosophical thinking about this question, but some of it, I think, not deep enough, because it involves a kind of dualism, that there's a person who's different than the embodied human being who we call a person, a sort of ghost in the machine who controls the body. That's an odd way to think about it, certainly not one that seems very scientific. Personhood can't just be the fact that we're able to have rational mental processes, because then we wouldn't be persons when we're asleep, and then you would say, oh, well, I don't mean that. I mean the potential to have rational mental processes. And so, well, maybe you say that infants then are just potential persons. They're not really persons. Maybe you want to tell that to a mother. I'm not sure the mothers of the world will accept that their child is not a person. Or you sort of have to commit to sort of saying that severely mentally retarded human beings are not persons. I think those are problematic. And there's also this funny legal conundrum you're in, right? So if you want to say we ought to be able to have assisted suicide for persons who are demented, the problem is that the law requires both that a person be terminally ill and that they have mental capacity. And so according at least to the current law in states where this is legal, Alzheimer's dementia doesn't permit euthanasia or assisted suicide because it's either too early if you're in the disease, or it's too late, right? If it's early in the disease, you're not terminally ill, even if you have the capacity to make the choice. And by the time you are terminally ill, you've lost the capacity to make the choice. So this is one of the reasons for the push. And that's why people say advanced directives would be the solution. But if we still want to call this voluntary, we have to ask how voluntary the suicide is if one is no longer capable of volition, and which is the case of persons who are in advanced stages of dementia. And you would say, well, it's precedent autonomy. It's the person I used to be who said this in an advanced directive. But that's led to some peculiar cases of actually to euthanize patients in the Netherlands, tying them down in order to euthanize them because they wrote an advanced directive 10 years ago that said they wanted it under these circumstances. And you sort of see in some ways, and Sam talked about slippery slopes, this is a logical and legal slippery slope, right? If we legalize euthanasia or assisted suicide, if we legalize assisted suicide for persons who are rational and terminally ill, these kinds of demands begin to creep up. So the person who's paralyzed can't take the pills, they would need euthanasia to be treated equally. And the person who's demented might have someone else making the decision on their behalf, either through interpreting an advanced directive or through, let's say, substituted judgment. Case 4. Now, maybe this is the one you don't have as a paradigm, but it's one that I think fits. Let's say you've got a 20-year-old man who grew up in a poor black neighborhood, who was paralyzed, through no fault of his own, getting in the crossfire of a gang shooting, who's now in a wheelchair, has a colostomy, self-catheterizes, not able to have sex, and is highly dependent on other persons. Might such a person say, my life is over. It is completed. It is actually ended. My life is no longer worth living. If we agree with allowing such a person to make such a judgment, it seems to me that that's an affront to the intrinsic dignity of that person, to who they are as human beings, to say, that's right. Your life, because it's dependent upon others, is not one that's worth living. What a failure of society and our obligations to other persons that would be to say yes to that. And moreover, once we allow first-person determinations that my life is no longer worth living, it seems to me that it's a very short step to allowing third-person determinations. Your life is not worth living. You're not worth our concern or effort. Now, of course, the pushback I will get, and I'm sure people are furiously writing their questions in now, who are you to tell me what to do with my life, that I'm not able to end my life whenever I want it? But that's an arbitrary assertion, and it is arbitrarily denied. I could ask back, who are you to tell us that we have to help you somehow in doing this? All laws and all morality limit our autonomy, and we limit persons' autonomy when there are good reasons for doing that. And we can't have everybody able to simply decide what they want to do on their own merits. Further, suicide is never a private act. The psychiatrist Ned Kassem says he used to ask patients who are contemplating suicide, in whose closet do you intend to leave your skeleton? Suicide is always an act of communication. That's what he was getting at, that it's always about our relationships with other persons, and it has deep effects on other people. In fact, suicides of family members have led some people to be very much proponents of assisted suicide and euthanasia. And state sanctioning of this and asking the medical profession to be involved makes it automatically not a private act. It depends on the assistance of others to give the prescription, to make sure that it goes okay, even if it's voluntarily stopping eating and drinking. So what are the alternatives? I say the alternatives are good palliative care. And most people fear becoming like that, a demented person, and lingering in that state for a long time. Such a person under my care or the care of any good palliative care doctor would not necessarily be prolonged. They don't need feeding tubes. They don't need antibiotics if they have pneumonia. They need to have burdensome and not very beneficial treatments stopped. They need the alleviation of their symptoms, and we are able to do more than we've ever been able to do in the history of humankind to relieve patients' symptoms. It's an odd time to be saying that we can't do anything, we need assisted suicide or euthanasia under those circumstances. And certainly that's not the motive of the Completed Life Project, where we presume people are not terribly symptomatic. Patients who are dying need attention to their spiritual and existential concerns, and we ought to find the right balance. We may determine that medical interventions are not worth it, but I don't think we should be saying that people aren't worth it. We ought never to intend, I think, to make people dead, but we also ought not to demand that they do everything necessary to keep their lives going. So I told Sarah at the beginning, the two philosophers I would quote would be Wittgenstein and Yogi Berra. My words are, it ain't over till it's over, right? That if a person is older or dying or disabled or lonely or tired of life, the response shouldn't be a lethal prescription or assistance with voluntary stopping eating and drinking. It should be to never ratify the idea, even if it's their own, that their life is not worth living, to consider every human being to be precious, to treat their symptoms, not to overtreat or prolong their lives with burdensome interventions, to address their concerns and their fears, to allow them to be our teachers until death takes them from us. So thank you. It's the end of my formal remarks, and I guess, Sam, you take it from here, and presumably now the fun or the fireworks begin.
Thank you so much, Dan. Fun or fireworks seems to me a false dichotomy, because sometimes the fun is the fireworks. And I thank you very much for your remarks. Much of what you had to say, as was with Gloria's comments, powerful, moving, and just pervaded with a sense of kindness and caring for others and respect. And clearly, it's incontrovertible that suicide is never a private act. With respect to Wittgenstein, he said a lot of things. He had a lot of suicide in his family background. And so his attitude toward suicide was very much conditioned by the traumatic experiences that he had in having to come to terms with the suicides in his family. Having said that, I'll say that if I had a choice between sitting down for dinner with Ludwig Wittgenstein in his prime or sitting down for dinner with Dan Sulmasy, I'd pick Dan Sulmasy every time. So your mic is off. Dan, you were muted.
I'm sorry. I thought you were going to pick Yogi Berra.
I see. I wonder, before we move to general questions, whether Gloria might want to take just a couple of minutes to comment on what you had to say, and I'll ask whether you want to comment briefly on what Gloria had to say. So a little bit of dialogue between the two of you before we open it up to other participants. So Gloria, do you want to offer an initial thought or two in response to Dan's comments?
Yes, certainly. Certainly, I appreciate the perspective. It's a productive critique. And certainly, this isn't a toxic challenge, right? And so as we are thinking about this, and one of the case examples that Dan cited really resonated greatly from the perspective and the voice that I'm trying to include in our discussions today. The example about the young man who is paralyzed, who's a wheelchair user, who has all of these things going on, and ask the question, given that he is highly dependent on others, might this individual, and really looking from the age of 20 to be again to say, what does my future look like? How many years might this go on? Is at the age of 20, is my life completed? Did I 21, typically in the old days, we would, complete our undergraduate studies. And did I self-actualize? Is that something that gives greater meaning and value and for me because of my background, from where I've come? Many people might not have achieved that, and I was able to do so. So this whole notion about dignity and respect is one that I think permeates all of these discussions, including the 20-year-old who says that, given what I know about my life, this life is no longer meaningful. It's no longer of value, and I'd like to end it here. I recognize that the moral chaos that could come about and the usefulness of having some criterion in place. But when I think about this, I'm reminded briefly about my own interests. What I know now, 3 decades later, was my interest in bioethics. I found myself as a freshman in a biology class, and Mrs. Hill created debate teams looking at the question about Karen Ann Quinlan. As you may recall, this was in 1976, a young woman in New Jersey, and there was discussions about whether or not Karen's parents should be a surrogate in terms of a decision maker and allowing Karen to die. And Mrs. Hill created 2 debate teams, one that was in support of the family's articulation of their preference to be heard and acknowledged and honored, and another that said that this should not happen. This should never be. And I found myself then on the side of really advocating on behalf of Mr. and Mrs. Quinlan, finding that their perspective, their voice, given the young age of Karen and what her life and future might be, and whether or not we should disconnect these life-sustaining and prolonging interventions to potentially allow a natural death. So I appreciate the tension that Dan is introducing in terms of first person and third person, and how do we create some parameters that we have some moral guidance and professional guidance to those that we might ask for their support and intervention. So it's more of a reflective piece in terms of some nuggets that I've taken away. So Dan, thank you for helping me to engage in this space.
Dan, would you like to make a few comments also?
Yeah. Again, thanks, Gloria. I'm, I guess, the one person who knew all 3 of both Gloria and Sam beforehand. So I always appreciate the chance to talk to Gloria, to listen to her, to learn from her, and I'm learning a lot today as well. One thing I'll start off by saying is that I think that the case of Karen Ann Quinlan and cases like that were also what got me interested in bioethics. But it always struck me that that was exactly where I wanted to go, right? Was that we should be able to sort of say that treatments are no longer worth it, not that lives are no longer worth it, right? So that we were able to stop the ventilator on Karen Ann Quinlan. And a good way to know what the intentions, for instance, of the family were to ask what they actually went to court for, right? They didn't go to court to make her dead. They went to court to stop her ventilator, right? That was their intention, and it was fulfilled, right? That's what happened. They won, and I'm thrilled that they won. But we all know what happened is, to their surprise, she started breathing. Apparently not to the surprise of the neurologist Fred Plum, who said, of course, she was going to breathe, but to the surprise of the family and all the people involved in the court, she began breathing, right? So the family didn't say, oh my gosh, she's still alive, let's take out a pillow to complete the task, right, and put it over her face. Their intention was fulfilled because they didn't want to keep her going with a treatment that they thought was unnecessarily burdensome. They did, for whatever reasons, continue a feeding tube, and I would have thought it permissible for them to stop the feeding tube as well. But their intention was to stop the treatment, not to make her dead. And I think that's a critical distinction that I've always held to for my entire career. And the second thing, going back to your talk, that you didn't mention explicitly, but I think needs to be brought out on the table, is the question of trust. Right? Trust in the medical profession, trust between the patient and the physician, or the patient and the nurse. And I've heard Richard Payne telling the stories that you told, and others like that. the legacy of Tuskegee, the legacy of the segregation of hospitals, leads the legacy of the way in which disabled people are treated, leads many of them to be incredibly distrustful of physicians and the healthcare system in general. In my view, the basic sort of Hippocratic thought that sort of says there are a few things that allow you to know you can trust me, right? Are that I won't take your life, I won't have sex with you, and I won't divulge your secrets, right? The fact that those are put up as basically absolute limits, I think forms a safe space in which people can, in fact, at least take those as the sine qua nons that says that they can be in a trusting relationship with that physician or nurse. It takes more than that, but at least that's the bottom line. And it's, again, one of the reasons that makes me worried, even in the setting of the pandemic. There are lots of disabled people who were fearful of going to hospitals because they thought their personal ventilators were going to be taken from them, right? It's that kind of distrust in a very rationalistic system that gives too much power, the power to end life, to doctors and nurses and other healthcare professionals, that I think is part of what engenders distrust, which is corrosive of a good healthcare system.
Mm-hmm. Mm-hmm.
All right. Shall we turn now to some of the questions that participants have sent in? They are, I might say, flowing in, and that's very much a benefit. And I'm going to ask your indulgence because this system only lets me see a couple of lines at a time, and some of the questions are longer than a couple of lines. So one question is, I'm looking for it now, directed to Dan Sulmasy, and it pertains to the phrase legally accelerated dying. And this is from someone who says that is a term that is in use and is even the subject of an upcoming workshop, but is not clearly understood. So I wonder, Dan, if you are familiar with this phrase and can say something about what it is best understood as meaning.
Sure, it's not one that I've heard before, but let me start by saying that it is like many of the phrases that have been introduced by the assisted suicide and euthanasia community, one that seems rather oddly ambiguous. Of course, we legally tolerate dying. we couldn't do otherwise, right? We cannot pass laws that say no one can die, right? So it seems to me that it is not actually a good description of what's being asked for. It's a way of sort of taking the edges off it, euphemistically making it sound better, but on the face of it, but rather confusing and ambiguous. The same way with issues like medical aid in dying or medically assisted dying, which are the terms of use for the community that wants to advocate for these. If you're going to be honest, let's talk about whether or not you want to commit suicide and whether you should do so on the basis of a rational decision, or at least purportedly rational decision that ought to be given legal sanction, not just toleration, but sanction through the assistance of the medical profession. So somebody like Peter Singer is at least honest enough to sort of say, let's not use these ambiguous terms. There's a debate to be had, and that's what we're having now, of whether rational suicide for people who've decided their life is complete ought to be legally sanctioned, and the medical profession ought to be given the opportunity or the privilege of being able to assist those persons in that pursuit. That seems to be just more honest language, and we can have a more honest debate. That's the question that's up for debate.
Thank you. Some of the questions cluster around the idea of future selves. And rather than pick a single question, I'll ask you each to respond to the theme of some of the questions. They have to do with the relationship between the views that one has about one's future. One questioner suggested that for a competent person to express the view that under certain circumstances that person's future life will not be one that should be sustained is itself a discriminatory act, an act of discrimination against a category of person which this person doesn't presently occupy, but foreseeably will in the future. And we do know that people often have clear, strong views about what they think they will want in certain circumstances, only to discover that when they are in those circumstances, their view changes. This is nowhere better illustrated than in Peggy Batten's stories about her husband, Brooke, who became a quadriplegic as a result of a tragic cycling accident. And Peggy, who had been perhaps the leading essayist in bioethics on these issues, learned from her own experience that some of her views about her own views did not withstand confrontation with the experienced reality of those circumstances. So the general question here is, how do we think about the relationship between what people think they are going to want and what is appropriate at some future time? Many of the questions that raise this theme talk about a situation that involves loss of mental capacity. And so one question is, if I am of clear mind, and not in a marginalized group, not having any of the insecurities or lack of trust so well described by Gloria, why should I not be able now to say that if I am in completely demented circumstances in the future, knowing that that imposes tremendous costs on my family, on the healthcare system, on others, why should I not now be able to say, if that happens, then it's no more? So let me stop. That was not a single question. It was a kind of result of putting 5 questions into a blender and giving you the resulting smoothie.
Gloria, do you want to start drinking in the smoothie?
We need to unmute Gloria.
Great. Thank you so very much. Thanks very much for the question. As you began, Sam, sharing the question, and I heard the future self, I certainly go back to advanced care planning and advanced directives, because I recall earlier on in my bioethics training, I believe it was Rebecca Dresser, who writes about this notion that by completing an advanced directive at the time that we say it's most ideal, there isn't a need. You are of clear mind, and you're not, in the throes of a medical crisis, that this is the time that you begin to communicate your values and your preferences and your choices in a way, and largely around limiting life-sustaining treatments in the way that, we've been talking, and that may ultimately include this next step of how we say this is an individual choice, and that also includes asking for assistance in aiding my dying. But Rebecca certainly argued about, who you are at the age of 25 may not be the person that you are, at 70, when arguably these instructions might come into play and might be useful to the healthcare professionals or even to families who are grappling with such a situation. And of course, her arguments are far more complex and thoughtful in that segment that I've just shared, but it really reminds me of, the competent person noun and our moral and ethical obligation to try to discern preferences while we're able. I think you also said that this person says that, I don't have any of the constraints that we've talked about. And if I am to be able to control my present self and my future self, ought I not be able to do so? And so I think that as we begin to think about what are the moral justifications for supporting that kind of thinking, the respect for autonomy would require us to consider that, I believe. My personal perspectives is that this whole idea about the last almost 3 decades of my work has been around providing information to persons, not necessarily that I am asking an individual to complete a directive where one might be able to articulate those preferences, but certainly that they have the information, the knowledge, that they understand that if they don't choose, someone else might choose in this space. So I am a proponent of suggesting that there is value to contemplating the future self, while I also recognize that it's not absolute. When we think about individuals, largely the Hastings Center in their Decisions project, one of the groups that was looked at was persons with disabilities, because this is voice that was certainly resonating from a advocacy group called Not Dead Yet, was really thinking that when it came to disabled persons, that there was a haste to judgment, a haste to making a decision, and so that future self was not in play yet as we were looking at the present self. So I'll rest here and say that these are the nuances. And so I would come out, if you said I had to make a decision, that I would be in support of allowing the future the voices of the present self to project their own values and preferences, and that we should be governed and guided by that those expressions.
And Dan, would you have a turn?
Yeah, well, I'd love to try to get into this smoothie, and maybe the philosopher in me is going to try to distill out the raspberries from the strawberries from the bananas in your smoothie. Let me start by saying that we're, I think, all in 100% agreement. All the questioners, Sam and Gloria and I, that there's value to people thinking about what might happen to them in the future, and to even recording some of that, or at least discussing it with other persons. Some of this stuff, gets into really kind of metaphysical questions about whether, if someone is demented, or is there a different person, which is sort of where Rebecca Dresser went, or these ideas of future selves that I have a lot of trouble with. I think it is the same continuous individual member of the human natural kind who is now incredibly sick and has a very diseased brain, is the same person, but is terribly sick and is not able to process information the way they were before. So for that reason, I would not argue that the present self is discriminating against the future self by, tying that individual down. On the other hand, let's say somebody said, don't feed me if I become demented. How strongly should we hold that, right? And someone like Norman Cantor wrote about this in the Hastings Center report, says, if I'm not, if I lose the ability to, whatever it is, play the piano, to do the things I love, to talk to people, then don't feed me, right? But what if Norm gets to that state, right? And he wants to go to the refrigerator? Do we lock it? Do we tie him up to the bed and say, no, you can't, because you said before that you didn't want to do that? And we really believe in what Dworkin says, your precedent autonomy ought to override your what's being said by the person now. And there is, I've told you, at least one case from the Netherlands in which someone was actually struggling and resisting euthanasia and was euthanized, and then it was reviewed by the courts afterward and said it was consistent with the person's prior wishes, that because that's what she said. And it seems to me that there's something really dehumanizing about taking the preferences of someone that literally and sort of forcing the individual to be held to those. In fact, we're not very good at figuring out what people would want, or writing down what we would want in the future. I mean, nobody says, well, if I'm ever in the situation where I'm not able to speak for myself, I've read the literature and I believe that renal dose dopamine actually does work, so please give it to me at 4 mics per minute, right? Nobody thinks in those categories, right? And so what I think we do, and my wife Lois and I have written on this, and we called a new model of substituted interests and best judgments. That what we ought to do is try to have decisions that are authentic to the person the patient is and has been, rather than trying to figure out this odd thing of what would the person have wanted based on their advanced directive or discussions that they had. So those values do inform the present, but they are by no means total, I think, and we can get ourselves into a real bind if we do that. And then lastly, the person who said, well, I'm not in one of those marginalized groups. I think you are. If you're a human being, you are intimately related to every other human being if you're part of a good society. And by distinguishing yourself from others and saying, well, they might not want it, but or it might be bad for them, but it should be good for me because I want it. That's already setting up the kind of divisions that I think we need to overcome if we're to have a more just society, because that person ought to consider what the effect of his or her decision might be on marginalized groups, such as, I think, turning the table, right? Once dependence on others becomes a state-sanctioned reason to be able to end your own life, then the person who is dependent upon others has to answer the question, why haven't you done it yet, right? The question is on the table for them continuously in ways that I think are very dangerous to the cohesion of our society. That person also mentioned costs. Again, I have no problem with refusing life-sustaining treatment. So, if you're getting, 10 units of packed red blood cells a day and you say, give the blood to somebody else, I have no problem with that out of charity. That's refusing a treatment and saying the treatment isn't worth it. It's not saying my life and I as a person am not worth it.
Thank you. Thank you to both for those wonderful comments. I do want now, before going to the next question, just to mention a comment that was provided, not really a question. Dan said that suicide is never a private act alone, and I endorsed that view. And one of the participants wrote, dying is never a private act either, that every death involves others. And that seems to me also a point worth acknowledging. Now, here's a question which I will put to you. Oh, only after telling a little anecdote. If I remember it correctly, the writer and humorist Art Buchwald, quite a few years ago, entered a hospice in Washington, and we know that this required a medical affirmation that his life was not more than 6 months. And if I remember the details correctly, it's a long time ago, 2 years later, he hosted a party in Washington to celebrate the many people who had been so kind to him during the 2 years he was in hospice care. And that, in a way, underscores, even if I don't have the details exactly right, the level of uncertainty that should make us somewhat humble about the predictions that are made regarding what is in store for people. That was very much the case with the Karen Ann Quinlan story. She didn't do as many people expected when she was removed from the ventilator. So here's what the comment says. How can you talk about autonomy when many people are misdiagnosed as terminally ill, are not actually dying, when insurers decide what treatment you can get, when people are exposed to coercive pressure to die because of burdensome care or financial reasons or ableism? So the thrust of this question is really how much autonomy is there in light of these very many different phenomena which corrode the legitimacy, the authenticity of the autonomy that we like to honor and praise. All right, over to either of you in either order. Gloria?
Okay. Well, one of the things that, I'm reminded as I heard the question, some work some years ago as a commissioner on the American Bar Association's Commission on Care of the Elderly, I believe, with Charlie Sabatino. And the work was really around individuals who were being forced to receive more care than they desired, that there were some competing demands or rationale being proposed as to why that was happening. And I recall, if I stay in the space of diversity, equity, and inclusion and voicing for marginalized and vulnerable groups, that's been not the experience that individuals are being offered more than they desire, that they're really fighting to say, stop, enough. That has not been the case. I mean, for many older adults who many times had jobs that they were productive members of our society, but perhaps they did not have access to health care as a typically that we enjoy with a provider or an employer who has that benefit for us. And so there are individuals who've worked their entire lives who are really waiting for the age of 62 or 65, when they are now being obliged with their red, white, and blue card, this universal access, this access to health care that they've been waiting for. And so this whole idea of, been waiting for so long, thinking that the day and the time is here, that we are able to get care. And so usually there isn't individuals that aren't turning away care, that we're saying that that they're being coerced in some way to receiving more care than not. Typically, what I hear is that, as healthcare professionals, we begin to make judgments about the kind of care the person is getting from a perspective is it beneficial? Is it futile? We raised the question of cost earlier about, whether or not in these last days of life, should we be expending these scarce and finite resources in the way that's being utilized? And so these are two very different positions, if you will. It was, as I understand the question, or my thinking about the question, about how do we talk about autonomy in the space of one who is terminally ill versus someone who perhaps needs to be a more substantive user of healthcare resources. Dan?
Comments, Gloria. I think you're right that in some ways, if we're doing ethics consults in the hospital these days, it's much more about the patient or the family asking for treatment that the doctors don't think is indicated, and it's usually somebody praying for a miracle or something that becomes the real issue at hand, rather than the old days when it was the doctors trying to overtreat the patient. But both pressures do still exist, and I think you're right to point out that it's not only toward overtreatment, but it's often toward potentially undertreatment as well. I wanted to comment, though, more on, Sam, on your anecdote and the part of the question about prognostication. Very good at who's going to live for 6 months or not. It's one of the reasons why the requirement in the law had to be changed from saying that you had to have only a 6-month prognosis, because many cares to the point that if they're living longer than that, they were denying payment. You're living longer. We can't pay for hospice for you anymore, and that was a serious problem. But we are not good at it. I know of a physician who's a strong advocate in the state of Massachusetts for legalizing assisted suicide there, who's been saying in state legislature for the last 10 years that he's terminally ill. is going to die soon and needs assisted suicide for that reason. So not good at it. Patients are not good. It does make it a little worrisome to sort of take this kind of a step under those circumstances. The other thing I wanted to comment on, the second part of it was about pressures and some of the more subtle pressures, particularly in the setting of the physician-patient, nurse-patient relationship, the possibility of what's called countertransference. Taking care of a terminally ill patient, taking care of a disabled person can be very hard work. Much easier to ask somebody to turn in bed than it is to actually have to turn them yourself, right? And I tell you, sadly, physicians and nurses get to the point in, what's the point, right? At least to themselves, what are we doing here treating this man? Of attitudes, even communicated directly, can be communicated in indirect ways that the patient himself or herself then experiences and feels and begins to then adopt as their own, right? I must be people, right? Therefore, what like an autonomous, the ends of those who are surrounding the person rather than the person's own truly authentic choice. And that sadly happens a lot in healthcare, and it adds a dangerous mix to legalizing assisted suicide, euthanasia, and particularly when we want to expand the criteria from it beyond terminal illness to just sort of saying, my life is complete.
Yes. Well, that last comment is reflected in one of the questions that was submitted. How do we know that people with advanced dementia are unhappy? Might it be that healthy people are simply discomforted by them? And we do know, even from what we have been learning in these last painful weeks and months around the pandemic, that there is a tremendous amount of selfless, unreserved dedication on the part of those providing treatment, but that there is also, in many contexts, a lot of discomfort on the part of the people who are constrained by circumstance to be providing that treatment. And so one challenge I think that we all face is to acknowledge the difficulty of achieving clarity about where the discomfort is, and to recognize our own, and also to be able to understand and properly assess someone else's discomfort. I want to shift now to a question that relates to Gloria's invocation of Nancy Dubler. When I think of Nancy Dubler, I think of things like Hurricane Sally, major meteorological events. Nancy Dubler is like a major meteorological event. And she said that bioethics is all about stories. And I think that's right. And that's what informs Ruth Bader Ginsburg's approach to being a Supreme Court justice, in contrast with some of those who are more theoretical, will look at the law and try to understand the law, whereas Ruth Bader Ginsburg likes to look at the people affected by the law and ask, what are they experiencing? What will happen to them? So yes, the notion of the instructive story is very powerful and pervasively important. But the question that was raised here is, how useful is it to draw our stories repeatedly from contexts very different from our own? So, for example, the Netherlands. Well, we turn to the Netherlands for examples, and some do that from various different perspectives on these issues. But the Netherlands is a very different kind of environment. It's small, it's got a different history, it's got a different kind of population. And so the question then is really about the difference between a good and a bad analogy. We use mice as models in the laboratory because they are like us in so many ways. There are other organisms we do not use because they are not sufficiently like us. Is the Netherlands sufficiently like us in the relevant respects that what goes on there should inform the decisions we make? What about Oregon? What about other states? How do we distinguish between the good and the not so good analogy in the acquisition and utility and deployment of our stories?
You want me to? Maybe I'll start on
Yes.
this one. First, I agree that stories are important, and even though my tendencies philosophically are analytic, I also appreciate the importance of narrativity and use it particularly in writings about patients, and sometimes they've been poems and sometimes stories about patients. And of course, the case history is a kind of story and has a narrative structure to it as well. That being said, well, the primary importance, I think, of stories is to make the ideas concrete and real, because we have to begin, I think, in good ethics from actual experience. So we need to have the sort of actual experience we're dealing with. It can, as Sam said at the beginning of his remarks, also help to highlight some of the emotional tone and aesthetic, other aspects that aren't necessarily in a purely medical or purely legal or purely philosophical part of it. So they sort of fill things out. But in the end, the story does need to be interpreted, right? Mm-hmm. The job, for instance, of a judge is not to tell stories, but to interpret the law and apply it to the stories of real people in actual ways. Otherwise, if that's what Ruth Bader Ginsburg is doing, she's not really being a good Supreme Court justice if she's really saying the law doesn't matter, just the stories, right? We've got to interpret those stories and apply the law to the concrete situations. That's background. With respect to the applying the experience in the Netherlands and Belgium to that in the United States, it is true that in the state of Oregon, the number of persons who are asking for physician-assisted suicide is still a very small portion of the population compared to the Netherlands or Belgium, where it's about 5% of deaths, actually. So it's much smaller than that. Nonetheless, I mean, I don't know, maybe this person has never traveled. I mean, I've been to the Netherlands, I've been to Belgium, I've been to Canada. I mean, they're human beings like me, and they're steeped in Western culture. Like me. I may be an American. I've got my own quirks because of that. But I think we have far more in common than we have that distinguishes us. And so when you look to those places, you have to realize, A, they started all of this a longer time ago. B, that they have been much more tolerant about lots of things. But C, we're moving, I think, in those kinds of directions about our social mores in general. If you think that the Dutch and the Belgium are, the Belgians aren't like us, I mean, the Canadians are a lot like us. They're different too, but they're a lot like us. And the rapidity with which a Supreme Court decision that said that people would have the right to what was thought to be assisted suicide became a right to euthanasia and the extent to which it's growing within Canada is stunning. How fast that's happening there. In the United States, we already have evidence that we're beginning to move in those kinds of directions. This whole project, for me, is actually evidence of that. It's not enough to be terminally ill, right? We've got to move it beyond the boundaries of terminal illness. We have legislation in Oregon asking for advanced directives, dementia for people who are demented, so that they can have assistance with suicide at a later date. Certainly people in the philosophical literature talking about psychiatric suicide, assisted suicide, assistance in that setting for, we have pressure from neonatologists to be able to euthanize severely deformed infants. So I think it's to say that we're so different from the people in Belgium and the Netherlands and Canada is simply wrong. That there are maybe political forces that have said, let's keep a hold on this so that we can get enough states to pass the legislation, may have more to do with what's happening than the fact that I think we will find ourselves within a decade, if it continues to go in the direction it is in this country, in just the same position as the Netherlands and Belgium.
Thank you. I do want to say a word of clarification about Ruth Bader Ginsburg. And it is not at all her view that the law doesn't matter, but her view that the law requires interpretation, that much of how we understand the meaning of the Constitution depends on how we interpret some of its provisions, and that there are different ways of doing that interpretation. And her approach to doing that interpretation begins with a focus on cases, but on individual stories, but absolutely does not end there. So
Good. I suspected that was true, but it wasn't the way it was presented by the questioner. So thank you for clarifying. I didn't think she'd make it to Supreme Court justice if it was just the way it was presented. So thanks.
Right. Now, I do want to go on to raise an issue, and this does not come from a submitted question, but it's just a question that I'm asking, and that's this. We know that a sense of being in control is tremendously important to people in many different dimensions. And there's a vast literature on control, on the extent to which people are self-deceptive about how much control they have. There are situations in which people have much more control than they realize, and situations in which people believe they have much more control than they do. This goes back decades to the classic work, The Illusion of Control, and all the experimental work about that. One of the domains in which this is manifest has to do with analgesic medication, that if you give a patient a drip that the patient can control, PRN, rather than a schedule every 4 or 6 hours, typically the patients actually use less narcotic medication because simply knowing that it's up to them lowers their anxiety, reduces the level of pain they're experiencing. Their need for the medication diminishes because they know they can control it. And so some people have claimed, and I think there may be some evidence of this, that people who have put in place the mechanisms that will enable them voluntarily to end their lives don't actually choose that option. They experience a better quality of life and choose to live longer because of the benefits of knowing they don't have to. And so I wonder whether you might have comments about that aspect of having a sense of control over one's ending, given that people, once given that control, often will be comforted and will make the choice not to play that card, not to use that option.
Gloria, you want to start on this one?
Thank you. Control is a very interesting one for many reasons. And I think that given the last part of your question in terms of, having systems in place gives one the comfort and the control to be able to exercise when one might do so. But I asked the question about, the individual and how does one get to this place of control? When you started out, you started talking about analgesia and control. And again, sort of giving voice to a segment of our population around, what are the values of healthcare professionals in thinking that one is in physical pain and how much analgesia is appropriate to manage that physical pain. There's a lot of bias and that's present as we read in the literature and as I talk to healthcare professionals. And certainly when I talk to patients with sickle cell disease, if you will, when they talk about their experiences about, reporting pain and the desire to be believed that they are physically suffering and that the amount of analgesia that they're requesting may sound outside of the range, if you will, but they're not drug seeking. They really are working to control the pain and that they're experiencing as a result of the disease. So I think that my initial thoughts about analgesia, I think it's an important one because as we think about, many of the drugs that we typically use that we say we make available to patients and families. Some families may decide that I don't want that for religious reasons, that I'm being snowed and that the person really is physically here, but they're not here because of that state. I also hear people report that God, I lost my train of thought just then. But the whole idea is that I think that control is really an important one, and control doesn't look the same for all persons. And that when we are dealing with attitudinal and biases, that really also shapes some of what goes on in general. And so the management of one's pain, the experience that one is having, and perhaps the desire to seek this additional effort has been largely born out of pain. I recall the early days with Dr. Kevorkian, as I'm reminded with Dr. Quill's comment, was that those individuals were complaining and reporting pain. When the right to die question, Quil v. Vacco, as I recall, going up to the Supreme Court, it was really about, individuals, lamenting about the uncontrollable pain they were experiencing. So I think that perhaps we've gotten better, and with the development of palliative medicine and the treatment and the specialization about how we manage pain, it has been improved. But at the same time, I think that this idea that we have a moral and ethical obligation to do no harm and to have people to physically suffer, it's something that is in conflict with professional codes of ethics and professional conduct. And as we reflect on Belgium or the Netherlands briefly, I remember some years ago I visited, and they were struggling with developing a patient bill of rights. And so I found it striking that we've moved in a progression around aid in dying and assistance when, as I understand the society, the people, the professionals were really trying to develop core tenets about what patients' rights might be and might include. And so I think some of those things are important foundationally or foundational for our professional practice as well as our clinical practice as we begin to grapple in the slippery slope of where the law might step in. Dan?
And I think this question of control is really central. Look at the data of reasons that people ask for assisted suicide. At the highest, right? It's dependence of life. I think all are in the arc of sort of I'm no longer in control, right? That I have to have assistance with dignity, dependent part of the motivation for even asking. But in the end, it seems to me that it's a kind of illusory sense of control. I mean, we'll use a story, the story of King Canute, right, who commands the tide to go back, right? And if the tide does not go back, and they realize it's almost as if the solution is, well, the tide is coming, the tsunami is coming, I can't stop it, so I'll drown myself. I think the tide still wins, right? I mean, I don't see this as this great exercise of control in the face of the overwhelming fact that we cannot control the fact that we are mortal, that we will die, right? Another great fact of human beings is you cannot choose who your biological parents are. Metaphysically impossible to choose your own biological parents, right? And you cannot love you, right? Because the moment you're in control, it is no longer free and therefore no longer love, right? So if that's true, if control is the central issue in your life, you have a philosophy which can't account for birth, death, or love. And I suspect you ought to go back to the drawing board and think about another approach to life. What we need is something like, the serenity view of the courage to change the things we can, the serenity to accept the things we can't, and the wisdom to know the difference. And that's part of what life is about. It's part of what good medicine is about. It's part of what good nursing is about. And to put too much emphasis on control inevitably involves controlling other people. We are social beings, irretrievably social beings. It is really dangerous to put too much of an emphasis on control, because if that's the central focus of your life, then you're going to spend most of your life trying to control other people so that you can control your own life. And that's a serious, I think, moral mistake.
All right. I am not going to try to make control the central feature of my life, but I am going to exercise some control as moderator and shift to a different segment of our program, because we've asked each of our two panelists to have a brief concluding statement, 5 minutes. And so I'm going to ask Dan Sulmasy to speak first for 5 minutes approximately as a concluding statement, and then turn to Gloria for her concluding statement. Dan, over to you if you're ready to do that.
But I really, first of all, again, want to thank the organizers for allowing a view that's program. I hope it hasn't been too disruptive. Those people didn't bother to show up today. I don't know. But again, I want to emphasize that I really have serious questions about how anyone can actually judge that their life is complete, other than, as was emphasized, in a very subjective way, and the problems that introduces of pure subjectivity in deciding whether one has access to euthanasia or assisted suicide are just, in my view, insurmountable. I think that I continue to be someone who's opposed to legalizing these practices, because I think they are bad medicine, bad ethics, and bad public policy. And if it wasn't for those three things, I guess I'd be in favor of it. I think it's bad medicine because, you know, the kinds of cases that Gloria was describing before about the person whose pain is not adequately controlled, we have to acknowledge as a medical failure, right? And we need to be able to make first-rate palliative care accessible to everybody. And there are plenty of people who have said that until we have a just healthcare system where access to healthcare and access to palliative care is available to people, that we shouldn't go about thinking about physician-assisted suicide. As a colleague of mine, Laura Finlay, once wrote, if the problem is with your healthcare system not giving you what you need, then fix your health care system. Don't commit suicide, right? That we really need to recognize how important palliative care is, and to make sure that people know that their fears that they will be in unrelenting pain, that they will be forced to live for long periods of time without assistance are false. And that we will actually be able to help them in many ways short of assisted suicide or euthanasia. Second, I think it's bad ethics because in my view, the central view of all interpersonal ethics, the central tenet we have to have, is that all persons have value merely by virtue of the fact that they are human beings and for no other reason. That value is one that Martin Luther King says he learned from his grandmother, who told him, Martin, don't let anybody ever tell you you're not a somebody. That being somebody, being a somebody, is the heart of Martin Luther King's theory of human dignity. My view is that every patient is a somebody. And that we need to remind them that they are cherished members of the society, even if we don't want to keep them here any longer than is necessary, that we not precipitate their deaths, because that is an intentional decision to turn a somebody into a nobody. And that, in my view, has got to always be wrong. And last, I think it's bad public policy for some of the reasons I gave before, which I think are good versions of the slippery slope, which is the logical and legal aspect of it, that once this is legalized in most, if not all, of the states in the United States, if that happens, immediately there will be lawsuits that say persons who are similarly situated but paralyzed need access to the same death. And therefore, we have to move to euthanasia from assisted suicide because a paralyzed person can't take the pills themselves. Likewise, persons who are demented will not have access or who are otherwise unable to speak for themselves, and we will have third-party judgments that grandma would have wanted this. And so we will move from voluntary to at least non-voluntary euthanasia very quickly. And so for those reasons, I think the entire project is asking the wrong questions. The questions we should be asking are, how do we make our palliative care system, our healthcare system, better address the needs of people who are older or disabled or sick or from marginalized communities that haven't even gotten basic medical care.
Thank you, Dan. Gloria? Wait, we need to unmute. We need to unmute Gloria. Okay.
Great.
Go, Gloria.
Thank you. The last few sentences that Dan just stated, if I could just underscore those statements, because that's the perspective that I really want to encourage. When we think about public policy, many have argued that this whole notion about providing information to individuals, that they have a right to complete an advance directive. They have a right to limit life-sustaining treatment. We thought that with the passage in 1992 of the federal law, the Patient Self-Determination Act, we thought that by providing individuals with this knowledge, that would somehow give rise to many persons completing documents and perhaps limiting life sustaining or prolonging interventions. So we haven't seen that. I mean, historically, we've been around 20, 25%, maybe 30% at large of people completing these directives and really setting forth their preferences in a way that might be useful to themselves, their families, and to us as healthcare professionals. But and because of the low number on the one hand, many have argued that this is failed public policy. But to underscore Dan's point, that this idea that not everyone knows about it and not everyone has equal access to it. And this equal access to healthcare and the health inequities and the health disparities that really shapes the life expectancy and the life outcomes that people experience needs to be a part of this discourse and deliberations. That I feel that, you know, COVID reminds us that, you know, health among members of our society isn't just, Norm Daniels talks about just health. You know, this is not just health. And that as we begin to think about influencing spaces, that I feel that we need to begin to think about how we can ensure that all members of our society, not individuals that I consider myself as a privileged member of society by virtue of my status and place in society, but rather to see privilege from a place of being a human being and being a person that's human, that's breathing, that's living, and that we say that we are our brother's keepers. We do need to abate human suffering in the way, and that shouldn't just be for persons who have knowledge about that or access to that. So I really feel that these health inequities and disparities that we continue to grapple with, and that we see that there's comorbid conditions that are really have affected some members in higher numbers and puts them more predisposed. And I do worry that values will be introduced and made to say that some lives are more valuable than other lives, and that will continue to create this extreme distrust among members of our society who have for 401 years have been, in a place of distrust, and that we continue to give contemporary examples of why some members feel the way in which they do, and that we haven't really gotten health care suited. And so I would certainly argue that the screen went blank. I hope I didn't overtalk.
We can hear you, Gloria.
Okay, thank you. So in summary, I certainly say thanks to the organizers and the thinking about the Completed Life Initiative and the Completed Life Project. And I encourage us to continue to think about persons who are missing, who are not in this room and not in this space and not at the table to give voice to different perspectives as we continue along this continuum. So thank you for the opportunity.
Thank you very much, Gloria. We have just a moment or two left. I will, prompted by Dan's invocation of Martin Luther King, point out that I'm perhaps the only antique in the program who is old enough to have heard Martin Luther King in person, and I have been struck all along with his affirmation that no one is free until everyone is free, his championing of the view that civil rights and human rights and the right to a decent life are inseparable, that poverty and discrimination of any kind are examples of an interconnected web, no part of which can be fixed in isolation. So let's bear that in mind. I also want to affirm my great appreciation to Sarah for all she's done to move this along, and to say that there are folks behind the scenes. The participants haven't known this particularly, but the questions have flown in, and Noah and Nicole, we thank you, even though you're part of the invisible infrastructure making all of this possible. So thanks to all. I look forward to continuing interaction with Gloria and Daniel, and strongly affirm their view that we want to keep debate alive and moving forward and keep the conversations sizzling with energy and with integrity and with candor and with an openness to views other than our own, because that's how we learn. Sarah, do you want to make one final closing comment?
Sure, and thank you so much, Sam, for your incredible insights in moderating this fiery discussion and debate. And thank you so much to Gloria and Daniel for your passionate and empowering points of view. We're so grateful to have you join us for this debate on such an integral part of the Completed Life Initiative and our mission, and your contrasting viewpoints and similarities at moments were very thought-provoking. And we saw many questions coming in. So thank you to our audience so much for participating and sending in comments and questions. We will work to summarize what you sent in and then publish the summarized version of these questions anonymized to our website within the week. So please look forward to that. And I would also love to look forward to next week's session 4, on the implications of medical aid in dying through a comparative and international lens. We have experts on legal policy and medical aid in dying. One from Canada, Jocelyn Downey, one from Australia and Queensland, Ben White, and one from the Netherlands, Agnes van der Heide. So we very much look forward to welcoming you next week for this important discussion furthering the conference. So round of applause to everyone here today. Thank you so much again, and we look forward to seeing you next time.